Mm-hmm. Yes, the fact that you can see a series of postures, and you can, from a series of postures, you can see or suspect a deviation from the norm of that trajectory or that vector, that could give you an insight into the possible error of movement. But
Definitely.
you still would have to confirm it by inspection. And even Pavel Kolage confirms it by inspection. He inspects the patient, and from that inspection, he decides if there's a problem.
Right.
No one can call it cold. And again, as you said, the individual variations must be accounted for. Not every flat foot is decentrated. And not every and not every centrated foot looks amazing.
Right.
Yes. So we must understand that this the anatomy is quite variable, and yet the brain is able to access it and use it in such a way that it gives it longevity and spares it from injury if the afferent quality is of a high enough standard that the decisions made in processing are going to lead to an efficient use of the segments.
Yeah, I mean, just to put like a practical example on these terms that we're throwing out there. I mean, somebody comes in with low back pain. What we're saying is that obviously you're going to do some type of local examination to their low back, but if you intend on giving them some type of stabilization strategy, whether it's based on DNS or not, if you're intending on giving them a stabilization strategy, number one, I think we're all in agreement that you can't just give them the stabilization strategy and then ask them how their low back pain is afterwards to determine whether or not the strategy was effective. That's not sufficient. The decrease in pain in the local painful symptom is not sufficient to tell you whether or not the treatment is ultimately effective or good. So what we're saying is, with this concept of joint centration, with this perspective, it's in addition to the local examination, you are, checking the range of the passive range of motion of the hips and the shoulders. You're doing a bit of a regional manual muscle test, just getting an idea of the general muscle strength or inhibition of muscles in the body, as well as palpation for trigger points globally throughout the body. Just collecting that data, which is neurologic objective data. Then you teach them how to breathe. You teach them how to effectively generate intra-abdominal pressure using the DNS model. Then you show them a particular DNS exercise, and you allow them to do it. And under normal circumstances or old circumstances, the only way for us to tell whether or not they're doing the exercise well is to just kind of look at them and say, yeah, it looks like you're doing it well. Biomechanically, these joints are all in a biomechanically centrated position, so it must be doing it well. What we're saying is, well, you can do a bit of that, but ultimately, once they're done, you can locally examine their low back, but then you globally go back and you check to see how the ranges of motion changed. Did they improve? Did they neutralize? Did particular muscles that may have been inhibited and weak get strong again? Did the sensitivity to palpation of trigger points decrease or completely abolish? Those would be the global neurologic effects that we would expect to see if someone was using an ideal quality pattern that we would have called centrated. So that's again, the way that is described, I don't see how that's controversial anymore. Once you get into that realm, it throws out all of the arguments, because now we don't have to look at the video of Usain Bolt sprinting and his knees kind of crossing over a bit, and people say, well, see, Usain Bolt's not using a perfect pattern, so how can you explain that? If you say, well, and I would say, well, I'm not talking about biomechanical principles. I'm talking about a neurologic effect. And
Right.
ultimately, I can't tell whether or not Usain Bolt is using a good pattern, because I'd have to examine him neurologically. I'm not concerned primarily with the biomechanics.
No. Because otherwise we cannot accommodate the individual variability. The dancer with a scoliosis who is stable and able to centrate her joints will have longevity. The
Totally.
person with a great spine who is unstable and cannot centrate her joints will not. So that is the wonder of this body, and the fact that it is governed by neurophysiological principles that dominate the biomechanics, and not the
That's
other
right.
way around.
The biomechanics, the norms that we're talking about, and the biomechanics, the range of motion, all that stuff, again, the category error is that those are separate from the neurology.
That's right.
The biomechanical principles and the norms came from the fact that we have universal subcortical programs of movement and stabilization in the brain, and that it's all the same pattern that everyone shares. That's why norms exist. But we forgot that. No, the term is neuromusculoskeletal. It's one term that cannot be separated. So you can't talk about just the muscular. I mean, we all know this. We can't talk about just the muscular system, the skeletal system. Ultimately, it is the neurologic system that is governing all of this.
Yes. So I think that it will be important. This is our take on the centration dilemma. It is not necessarily the official take of the DNS school, but in looking at the difficulty in explaining joint centration, we have to try to come towards a practical solution that allows us to assess the patient, determine if they need help, apply that help, and be able to check that we have actually made a move in the right direction. Because one of the first things, when we have ideal motion, then we have maximum range of motion, maximum capacity for strength and force production, and minimal nociception as a consequence of that movement or that position. So we must look to the effects of centration as the markers by which we can judge centration, not by its position, because the position tells you nothing about the afferent quality. It just merely indicates a certain angular relationship between two segments that abut each other. But not only we're not dealing usually with two segments, we're dealing with a whole chain of segments that must coordinate themselves. So one segment alone does not rule the body.
That's again, it's at least as DNS practitioners and most other physical medicine people who are serious understand that there are no local effects. Everything does have a global effect.
That's right.
And we say that overtly in a DNS course, but then you fall back into there's no local effects, everything is global, and yet you're concerned about the local biomechanical position of that one joint that you're attempting to stabilize, forgetting that has a global effect that should be inspected or analyzed or assessed.
It's the global inspection that helps you know that the local joint is giving ideal information. So the local or singular joint doesn't rule by its position, it rules by its effect, its global effect. And therefore that is the only way to date. In a few years, we might have better sensors. We might have the ability to draw blood on the spot and see stress markers arise from poor movement. We might have a whole host of other measurements that we can take. But when you're in a room with a patient and you're trying to improve their efficiency, we have limited access to sophisticated equipment. We have limited access to testing of such a high technical level that we can easily use it and have the patient move. We are not usually under laboratory conditions to perform our interventions. We are usually in a room with a table and a mat and some TheraBand. So good luck with that.
If you enjoyed this conversation and want to hear more like it, then please like this video and subscribe to our channel. You can also stay up to date on our latest seminars on our social media pages on Instagram and Facebook at IMTR Seminars.